Thank you very much, Miguel. I actually hate this topic, but I talk a lot about it and I write about it, but I still don't know what it is. So, what are the problems in dyspepsia? The first problem, and the biggest problem, is interpreting these symptoms. Another challenge, which we hear more about later, is the whole issue of the role of Helicobacter pylori. And then, for the clinician, how do we go about assessing these patients? I still don't know how we should do it. And as Miguel just mentioned, our biggest challenge is how to treat these patients. We do not have a lot of good treatments, unfortunately. So let's talk about the basics of dyspepsia. Here I'm talking about all of dyspepsia, not just functional dyspepsia. It's certainly common, affecting up to 29% in the community, and it is associated with various personal factors, like use of tobacco, alcohol, and non-steroidals. That's all been shown epidemiologically. And of course, what's important is that it has a significant impact on quality of life, including personal and societal costs. That's why we have to talk about it. Now, one of the things that's happened over the last 100 years is that there's been a significant change in the prevalence of causes of dyspepsia. So as we've gone through the last 100 years, we've seen that the prevalence of peptic ulcer disease and gastric cancer have decreased, and the prevalence of irritable bowel syndrome, reflux, and functional dyspepsia have increased, which has made our life a lot more difficult because they're more difficult to define. Now, dyspepsia is not a disease, but it's a symptom or a symptom complex. And the problem is that it's a medical term which we arrive at following the interpretation of a patient's symptoms. So what symptoms should we include? Pain, discomfort, satiety, satiation, fullness, bloating, nausea, vomiting, heartburn. To the patient, these may all mean dyspepsia, but what do they mean to us? Then we ask additional questions. What is the location? And what are the associations? If it's associated with bowel action, we think irritable bowel syndrome. If it's not, it might be dyspepsia. And the problem is that most of these symptoms are very nonspecific and also of relevance to you. How well do they translate from English into Spanish or other languages? They don't in many cases. So we have a difficulty in communication. Now I have to talk about Rome 4. Fortunately, Rome 4 is very similar to Rome 3. And these are the functional gastroduodenal disorders. Functional dyspepsia, 2 subtypes, postprandial distress syndrome, epigastric pain syndrome, belching disorders, of which Professor Smout is an expert, and then very importantly, a new category of nausea and vomiting disorders. Chronic nausea and vomiting, cyclic vomiting, cannabinoid hyperemesis syndrome, and rumination syndrome. And these are very important, I believe, to differentiate from dyspepsia. Now, functional dyspepsia, according to the Rome classification, involves one or more of bothersome postprandial fullness, early satiation, epigastric pain, epigastric burning. And of course, no evidence of structural disease, which means endoscopy, and criteria should be chronic, not acute. In Rome 3 and Rome 4, functional dyspepsia is subdivided into two groups. The first is the postprandial distress syndrome. In Rome 4, there are some differences with regard to symptom frequency. So postprandial distress syndrome, bothersome postprandial fullness, occurring after meals, or bothersome early satiation. And this should occur at least 3 times a week. That's a new definition. And the epigastric pain syndrome, bothersome epigastric pain or burning at least 1 day a week, quite different. It shouldn't be like irritable bowel syndrome. It shouldn't be biliary. Now, heartburn can be present, and this is the difference from Rome 3. And they also acknowledge that in many patients, there may be elements of both. In Rome 3, there were, in my opinion, 2 major problems. First of all, they attempted to separate functional dyspepsia from reflux by saying, while the pain may be burning, it must not be retrosternal. And secondly, they differentiated functional dyspepsia from irritable bowel syndrome by saying the pain should not be relieved by defecation or the passage of flatus. My problem with this is that I believe in clinical practice there is great overlap between reflux and dyspepsia and between dyspepsia and irritable bowel syndrome. I often can't tell the difference. And Rome 4 accepts this overlap to a greater extent, and that's a good thing. Now, how common is functional dyspepsia? This is a very good study from Italy, which showed that 15% of a general population had dyspepsia in general. Of these, the majority, it was functional dyspepsia. And meal-related symptoms were most common. But you can see that 16% had both meal-related symptoms and epigastric pain. And as I mentioned earlier, psychosocial factors, unemployment, divorce, smoking, were significant risk factors. And as I mentioned earlier, there was a lot of overlap with irritable bowel syndrome. One of the problems for us as clinicians with dyspepsia is what I call the symptom trap. The first one is that the alarm symptoms that we all learn about are of limited value. And also, unfortunately, symptoms are unhelpful in predicting response to therapy, with the exception of heartburn, which will respond to acid suppression. And in clinical trials of dyspepsia, the inclusion of significant heartburn is a great contaminant. This is a study from several years ago, which was a review of alarm symptoms and showed that their sensitivity was highly variable, as was their specificity. But a clinical diagnosis by a physician was specific, but not very sensitive. And this is a more recent study from China, fairly large study, and you can see the sensitivity even of dysphagia, weight loss, bleeding, vomiting were extremely low for GI malignancy. So the majority of patients who have these symptoms will not have cancer. When we talk about dyspepsia, there are critical clinical issues in the definition. When you read a paper, the first thing you must recognize is this study in patients who've been investigated or not investigated. Is reflux included or not? And this shows you here the differences in the percentage of these various symptoms in reflux esophagitis in general, in reflux esophagitis, which are low, but you can see in non-erosive reflux disease, the overlap with functional dyspepsia, and particularly the epigastric pain syndrome, is extremely high. Do you allow irritable bowel syndrome? As I mentioned, there's an extremely high overlap between irritable bowel syndrome and dyspepsia. And how you define the patient will dictate your outcome. So if you take all dyspepsia, then you're talking about uninvestigated dyspepsia. However, if you do Helicobacter serology or endoscopy, you're now talking about investigated dyspepsia, which is quite a different entity. And this will be separated into organic and functional components. I want to say a few words about pathophysiology, because there have been some new developments here. This is from our recent review, which summarizes the traditional factors like delayed gastric emptying, impaired accommodation, Helicobacter pylori, but also mentions some new factors like duodenal eosinophilia. One of the great difficulties here, could I have some water? Oh, there's some here. It's here. It's here. Sorry. Is the problem of gastric emptying. There's a major overlap between gastroparesis and functional dyspepsia. But unfortunately, gastroparesis is not very helpful because delayed emptying does not predict symptom pattern and it does not predict response to therapy. And in patients with delayed gastric emptying, it's common to have other pathophysiological factors. And this study shows how complicated the situation is. These were patients with unexplained nausea and vomiting. Some of them had normal emptying, some of them had delayed emptying. No differences in demographics, no differences in symptom severity, no difference in impact, slight differences in anxiety, but overall, these patient groups were indistinguishable based on gastric emptying rate. The impact of Helicobacter will depend on your patient population. If it's uninvestigated, it will be important because you will have some patients with ulcers and even cancer. And here, test and treat will work. But in functional dyspepsia, where you've excluded these conditions, the impact will be much lower. And this is one of many meta-analyses which show the small therapeutic gain for eradication in functional dyspepsia. There is one new syndrome associated with dyspepsia, and this is Ehlers-Danlos, or joint hypermobility syndrome. And you can see that in these studies from London, there was a significant increase in the prevalence of functional GI disorders, and in particular of reflux, bloatedness, and constipation. So what are the clinical issues? Who should you investigate it? All patients? Certain age or demographic groups? Based on alarm symptoms? This will depend entirely on your local situation. How do you test with Helicobacter testing, endoscopy, or a therapeutic trial or test? So test and treat is one approach. Do endoscopy and treat, or just treat empirically with eradication or acid suppression or a prokinetic if you have one. or do all these investigations and then treat accordingly. In terms of when we come to functional dyspepsia, having excluded organic disease, again, your options are test and treat, investigate, or treat empirically, or on the basis of symptom predominance. A lot of these have been studied. This is a study in primary care, which looked at a comparison of test and treat versus empiric PPI, and basically showed very little difference between the two. However, even for costs, there were minimal difference. This was in the UK. There are some clues. Who will not respond to acid suppression? Female patient, the patient who has more motility symptoms like early satiety and postprandial discomfort, who has epigastric pain and nausea, and in particular, the patient who has no reflux symptoms. So I'm trying to be as good as Professor Smout. Here's my algorithm. So if you take all dyspepsia, which is uninvestigated, test and treat for Helicobacter pylori will work well if you've got a high background prevalence of Helicobacter pylori. Endoscopy will ultimately separate organic from functional, and empiric PPI therapy is a reasonable approach if reflux type symptoms are present. If you've got functional disease, you've got many options because none of them work very well. And we suggested if pain is predominant, perhaps a tricyclic, nausea and antiemetic, early satiety, a buspirone. But there are new ideas out here. I mentioned eosinophilia, post-infectious functional dyspepsia. There are some new prokinetics like acetiamide. I've mentioned the fundic relaxants, and there are other approaches like psychotherapy and herbal preparations. And to finish, I'll mention a few. I've already warned you that gastric emptying is problematic. And whenever you think about gastric emptying and motility and prokinetics, remember itopride. This was a study in the New England Journal of Medicine which showed a significant response to itopride. 2 subsequent phase 3 trials showed no effect. The difference between the 2 studies, in the phase 3 study, they excluded heartburn patients. But there is some good news. If you're addressing visceral hypersensitivity with amitriptyline or other antidepressants, there is an effect. Amitriptyline, but not escitalopram, is effective, especially with pain, but has no effect on gastric emptying, and this was recently supported by 2 meta-analyses. Other studies have shown that tricyclics had no benefit in delayed gastric emptying. This is the large study from the NIH consortium. For impaired accommodation, I've mentioned mirtazapine. I've mentioned buspirone. This is a recent study looking at mirtazapine, showing an effect on early satiety, on weight gain and nutrient intake, but no differences in overall symptom score. But this does seem to have some effect in selected patients. So in summary, the first problem with dyspepsia is that it's a symptom or symptom complex. It's not a clearly defined biological entity. As a result, it's susceptible to all of the pitfalls of symptom interpretation. Its definition, though controversial, is critical in determining outcomes. Remember to differentiate between investigated and uninvestigated dyspepsia. I must have gone the wrong way. As organic cause of dyspepsia recede in countries, non-organic reflux disease, IBS, and functional dyspepsia will loom even larger. In my opinion, unlike reflux and irritable bowel syndrome, functional dyspepsia is not well defined. and it often overlaps with reflux and irritable bowel syndrome. And in clinical practice, its separation is somewhat arbitrary. The big problem in terms of new treatment is that in functional dyspepsia, pathophysiological correlations with symptoms have been poor, with gastric emptying, with accommodation, with any of these other conditions. As a result, it's been a minefield for new therapies. Those of you who've been around for a while will remember the many, many therapies that were introduced for dyspepsia and for functional dyspepsia in particular and failed. Thank you very much.